Good afternoon, everybody.
Howdy.
Hello.
Greetings.
Nice to see you all today. Thank you for joining us on a busy afternoon. So let's just get started out of respect for everybody's time. I'm Vanita Leadham. I'm with the South Carolina Birth Defects Program. And I'll let my other colleagues from MCHIP and Brendan introduce themselves.
Oh, I'm Brian Martin from the Vermont Department of Health Birth Information Network.
Hi all, this is Justin Huang. I am the liaison between MCHIP and NBDPN.
Okay, well, shall I continue, Brennan?
Please do.
Okay. Okay, well, we're excited to have you all. This is a topic that came up at the last listening session. And so we have some questions we're using kind of as jumping off points to discuss data systems and data collection systems. So the conversation is fluid, it's open. If you have something else you want to talk about within the context of this or something related, we're happy to pivot. But just want to hear your thoughts and what your needs are in the area of data collection systems. I don't know if you want to add anything to that, Brennan or Justin.
I think that summarizes it well.
Okay. So I'll just start with the first question. What system are you currently using to collect data? And how does the system meet your needs?
Well, I can kind of kick it off a bit as well on that. Vermont uses an access system that was generated by my predecessor once removed. You kind of scratch built it, and I inherited it, and this have been kind of like immersing myself in it. It works well for our purposes, but one of the downsides is if I get win the lotto tomorrow or get hit by the lotto bus, Vermont could be in some bit of trouble because it's not exactly user friendly.
That's funny.
Hi, this is Kathy in Massachusetts. We also use an access-based system currently. It has its pros and cons like anything, and we luckily have an on-site programmer who can make a lot of changes with flexibility. It is pretty sophisticated, I think, right now, but we have been told to transition our way out. That's where we're at because of access not being, kept maintained, I assume. So we're trying to work on moving to Apex Oracle. And so we appreciate this session just to hear about other people's experiences, and hope to be able to reach out to some folks if we need to. It would be great also. Thank you.
Yeah. So as people are talking about their databases, I think it'd be helpful to make a distinction between what you use to collect and manage cases and what you use actually to create your repository that you use for analysis. They might be completely different systems.
In Vermont, I have a core access database, which is run by kind of a constellation of other little databases. And so there's other bases where do some of the processing for individual data sources, and things stream into the core database, and things are reviewed, accepted, and then the work done there. And the actual analysis is done by queries who live in that system. It's been suggested that if some point we need to transition, that it might, or for other reasons, it might be beneficial to have some kind of discrete repository of confirmed conditions, which is, can be done, but a point where I haven't actually felt the need to spend the time to make that happen, and then corresponding also like making sure that it's actually correct, and then ongoingly keep making sure that this additional auxiliary system is properly in sync with the where most of the work is actually done.
Yeah, with our system, I think we do a lot of data management within Access for sure, and receiving same thing, receiving reports in other formats and translating them, making them crosswalk into Access. Most of our data analysis beyond like quality checks is done in SAS. And, things are exported from Access into SAS into maybe a couple other formats, but a lot is done within Access, I would say.
Kathleen, can you kind of elaborate on what you recall being told about why you must migrate?
Well, I work DPH, and they are transitioning a couple. We're not the first. I think we're the second, I believe, but they just don't believe that Microsoft Access will be kept. It will be maintained by Microsoft in the future, and that as other the systems around it gets upgraded, I think it's less and less cause more issues. So the cloud is the future, I guess, and so they have chosen Apex Oracle. We didn't pick that, so we have to go along with that. But they do say that we have to, what our process is, we just have to look at all our systems. We're taking that opportunity to look at everything. How would we like to be in the future in this system? So, but yeah, we were just told that that they don't want us to stay.
And can you elaborate on who exactly is they?
Like the major, like we're within DPH, within the Executive Office of Health and Human Services within the state. So it's coming from the very high up within the state.
So on a financial level, I'm just wondering whether at some point you could be liable to help pay for the cost of Apex Oracle licenses or other issues like that, because it's a pretty high-end application that is pretty expensive to have a agency-wide license.
Yes, I believe since they've already started, they may have some of that taken care of. I know they've even identified some money. I know that stopped us in the past, is the cost when we've looked at like Maven and a few other systems that stopped.
Actually, our transition to Apex Oracle was dictated kind of like of the cost comparison with other systems, and we'll have to pay like some part of the costs for transitioning, and then there's the maintenance cost that we'll have to pay every year.
Yeah. Now, bear in mind those costs, you can't get away from having to pay for costs for your data system, both for software expense as well as for staff to manage and maintain it. So those are going to be ongoing costs. I just worry about, thinking about Access versus Oracle, just for example. That's a pretty quantum difference in expense,
Yeah, I'm always very interested because on various conversations, there's been like hearing that, quote unquote, they said we must. So I'm always trying to pick out, is that
who are they? Are they us? Yeah, exactly. Yeah.
So
well,
I'm sorry.
I was just going to say, in Florida, I've been in Florida since 2008, and at least twice we've had extended conversations with Florida Department of Health IT about converting our system from Access. And each time after they actually study what we have and what it does, they just kind of hold their hands up and say, no, you guys can keep doing what you're doing. But again, that's for the data acquisition side of things. What we have the data actually stored stored in, where FDOH is completely different. And I don't know, I think Amanda, you're on the call also. Do you want to say anything about that? Didn't want to put her on the spot.
Sorry, Russ. No, sorry, I don't have anything to add. But yeah, every
Yeah.
time that we sort of veer away from access due to its, general limitations, we sort of end up going backwards.
Yeah, and this is Jason. I created the database in Florida and continue to kind of upkeep it. And it is true what Russ is saying. I mean, a lot of this has been, and even when USF IT actually, because we're partners of the Florida Department of Health, and so USF IT has come out and said, okay, we're going to migrate you to something different. Access just doesn't work. As soon as they look at the database, as we say, it's not your mama's access database. There's a lot of functionality that's baked in. Like, we really maximize the use of access. And again, for something where we don't always have internet connectivity, where our abstractors are, it is a cost-effective tool that does everything that we need from the data collection side right now until something changes. We do obviously then export that data to either R or SAS for data visualizations and analytics, and incorporating with any sort of a website. So it is very different. But for the data collection side, we have not found anything that is affordable that our abstractors can use everywhere that they go. Like, we've even got it where our field databases, when those access databases come back in, they sync with our master. Like, there's a lot of functionality that we've baked in. And so for us, it continues to be the tool that, like Russ and Amanda said, they'll say, okay, we're going to do something different. And they're like, well, what you're doing actually works really well for the money that we're spending on it. So everything is situationally dependent, I think.
Yeah, exactly.
I was wondering if, this is Irini, I was wondering if at any time, because as Kathy mentioned, for us, it has been the fact that at some point, the Microsoft Access will not be supported. Has this ever been discussed with you at all? Because for us also, our Microsoft Access database is extremely complicated, and when we are presenting it in order to set the path forward to migrate, you can tell that it's very, very.
No, that's an excellent point. And I think that the key thing is that we have our own staff who built the database and understand how it works and all of its functionality. And we've tried to build redundancy into that by having several of our staff, with the capacity to do that. If it is an issue, if you're going to be relying on agency-wide IT, and they don't feel they want to have somebody who has, expertise in Visual Basic and high-level programming within Access, that's definitely a problem.
Well, and Irini, this is Jason. To answer your question, I hear a lot of things about a lot of things that are going away and coming here, and that's been for decades that I've heard it. I've not seen anything like on the forefront. This is definitely happening. Obviously, there would be a number of years, I would imagine, that if a product was actually going away forever, I imagine we would have enough of a warning. This is not an institutional decision, but if Microsoft got rid of Microsoft Access and it was no longer going to be a product that we could use in the future, then we'd have to migrate to something different. But I hear through the grapevine that so many things are going to happen, and then 5 years later, what they said was going to happen in 1.5 years hasn't happened in 10. So again, we monitor things. We try and be at the forefront of if we're going to have to change products, and we're happy to do that if you pull our arm. But at the end of the day, we want something that people can use. I know it's not the fanciest thing in the world, but it works very well for what our objectives are. And so I think each program would have to answer that question for themselves. It's a balance of, do you have the capacity to upgrade it and do the things that you want? Do you have enough control over it? And does it achieve the objectives you need that tool to achieve? And again, for us, we know it's not the fanciest thing, but it does exactly what we need it to do. And then we have other program software that we use for the analysis and reporting side of things.
And I somewhat agree. I mean, I've asked around I used to participate in an IT chat room, essentially. I did with people who are much, much more savvy than me. And I floated this thing out. It's I hear from IT that Access might be limited support, and it bounced around themselves. And they didn't get the feeling that there was any imminent chance of Microsoft pulling the plug. So it makes me wonder. I think there are definitely limitations of access, and I think it might be that, and then certain circumstances where a program might have to go ahead and transition. For example, if they are relying on IT support and IT says they just want to support access, that might be one. Or also, a thing I've heard is like if there are size limitations to access, so you might, if you might be knowing that what that is, you might be able to project that yes, by 2030, given our birth rates and this how many kids are born, we'll likely hit that number. So we might want to get ahead of that before we stumble upon it when things start throwing errors. I don't think Vermont's going to be in that circumstance, just given our number of births. But what might be good to kind of maybe at some point hammer out and write down what are the kind of triggers for and that would make at least for access a transition to something else beneficial or even possibly even absolutely necessary. And if so, that's a program can kind of figure out, yeah, we're good for a time foreseeable, or yeah, 5-10 years we really need to find a new solution.
Hi, this is Bruce Hulsey from Arkansas, and I work for our university's IT department, and I contract to the Arkansas registry. And our system was an access-based system for years. And I moved the data to SQL Server. And I am perfectly comfortable that this is a solution that will last a lifetime. I mean, the idea that access is going to go away in any shape or form. I mean, there are limitations to it as a database, but as a front end to another database engine, SQL Server, Oracle, whatever.
Right.
It's a very powerful tool. And would love
really
to discuss any of this offline.
Yeah.
That's really good to hear, because that in North Carolina, our IT department is also kind of pushing us to migrate out of access. So what I have opted to do is just migrate the data on the back end to SQL Server and continue using access as a front end. So if that works out well for people, that is encouraging to hear.
And that's a solution that a lot of people are doing. But I'd be interested to hear two things. Firstly, if there are any states that are using applications like Maven or Merlin or similar kinds of applications. And secondly, if anybody's started to experiment with HL7 based messaging as a way to input data and how they're managing that in terms of their IT.
This is Barbara from Minnesota, and we use Maven. We call it MEDS. So if you hear us say MEDS, we mean Maven.
Okay.
And we are doing a readiness assessment right now with our IT. Our IT is it's its own separate agency, and they have contracts with the health department. And that was a big transitional period. Like we used to have our own access database that like one of our staff built. And, we also heard that this was going to go away eventually, and that was well over a decade ago. And clearly access is still around, although it's not well supported. I don't know if our IT supports it anymore. We kind of piggybacked onto the Maven project that infectious disease was working on. And this was around 2008, 2009. There was a group, EPIs, got together and listened to a lot of speeches about how great these products were, and they picked Maven. And so we went live in 2010 on Maven, and we use it to collect our data. So it's our front end. We do export our data out and use SAS to analyze it. And what else did you ask? We aren't very far with HL7 messaging, but Maven itself was selected because it could accept messages. And so a lot of our infectious disease and COVID was on meds too. So there's lots of lab reports, all that stuff is coming in on various messaging, modes. But we're very early on. And yeah, the system itself is capable of it, and the infrastructure exists. It's not the most mature, but it's fairly mature. Like the structures are there. It is kind of expensive, but we're fairly well funded. So we pay $13,000 a year is our share for our, what is it, our annual maintenance fee. And then we pay, we support about a little over a third of an IT staff person to, you know, tweak it and configure it how we want it. If we want to do special projects like big builds or data transformation, then we have to get the attention of Conduent, which is the company that owns Maven. And right now that seems like it's hard. Like if we wanted to do major overhauls, we would, you know, you have to vie for the attention of a company that has, you know, a limited set of resources. So it's great in some ways. It's not perfect. So, and it's fairly expensive. You know, every year we spend something like, I would say 60 to 70,000. And that's only, that's not including our own staff time, right? Like our EPIs that work on it and use it, you know, but when they are designing changes and developing things, I'm not even counting that. I'm just talking about IT staff.
And Barbara, thank you so much for that. So you have, what are the advantages versus like the previous system, the access? And also you said that the maintenance fees is 13,000 or 30,000?
13,000. And I think that's 13% of the all of the maintenance that the whole Department of Health spends. So we're just one share. So we have a slice of a pie that we pay. You know, I think that our access database, you know, we didn't really have the staff expertise in building a database, and the way our IT support was becoming its own agency, they do influence our decisions. I don't think we had much of a choice to keep the access database. But I wasn't really with birth defects at the time all these decisions were made. I was, you know, I remember them building the initial database, the access database, just with regular staff, not even IT staff. And then when we started building meds, you know, there were multiple programs kind of onboarding to meds at the same time. And I think that was the initial onboarding was funded through different sources. It certainly wasn't birth defects paying its way then, because we didn't have any funding at that point. So we were sort of riding on people's coattails. You know, I mean, it's powerful. Does anybody else want to weigh in? I know we have other people from Minnesota saying what they like and don't like about it.
I was going to say, this is Joanna from Connecticut. We use Maven. And I'm actually not the birth defects person. We have a new person, so I'm kind of sitting in just to fill in a few details. We've been using it for a few years now. It is expensive. Our newborn, our birth defects has no money. So they have kind of, the other programs that use it have been paying for our share. It's very expensive to get updates. And it's nice in that it's, we have our newborn screening program in Maven, so that when the hospitals enter the newborn screening data, they can also enter the birth defects data. Our newborn screening program, though, is looking to transition to something else. We don't know if they're going to transition totally with Maven, or because they're talking about changing their HL7, which now goes into Maven, but they want to change from HL7 to some other system. So we will probably end up changing too, because we kind of just ride on their coattails. And I guess that's about it.
And certainly kind of struck by just the price tags that are floating around here for Maven. Yeah, some of those things, values that are kicked around by Minnesota. It's like, wow, that's a pretty much good chunk of Vermont's birth defect budget right there.
Yeah, you know, and actually, this is Joanna again. Our instance of Maven right now has our children with special health care needs on it, our newborn screening, our family wellness healthy start, I know birth defects, but that's just one instance. We have other instances within the Department of Health. So Maven is making a lot of money out of us. It really is very expensive, especially whenever you want to make changes, which, you know, that happens. So it is something that you kind of, you definitely have to budget for. And if you're going to be, you know, you're going to be making a lot of changes, you know, it's any changes are expensive.
Brendan, this is Barbara from Minnesota. We also rode on coattails. Like, we didn't pay much at all except for staff time for like developing and implementing. And I, you know, when you look at how, you know, big companies implement these sort of like integrated platforms, it's like super expensive. And most health departments don't have that sort of infrastructure support, I don't know, indirect, that is capable of paying this much. But I don't know how we would have sustained it with the funding that we had in 2009, 2010. We got state funding sort of, it wasn't totally out of the blue, but it kind of was out of the blue in spring of 2010. And the way we built meds, a lot of it we rebuilt, and that was out of our pocket. So my experience with watching other programs go live in Maven, you know, if they didn't have funds to support internal IT staff who could configure it and make changes, was they were kind of stuck. They like, you had to, it's just hard. I mean, you have to be fairly well resourced. I don't know that it's, unless your whole health department moves this direction, and ours doesn't. Like, our newborn screening uses something else, and our family home visiting uses something that I think they built. And, you know, but a decent chunk of infectious disease, some environmental health, and CYSHN are using Maven. And so we can kind of pool our resources. So we budget for that staff time for IT. Even if we don't always use it all, it's still covered, like that support exists. It's expensive.
I think that's actually a very good kind of take-home lesson. And it's like, at least if people start having conversations with IT about IT pushing them to do something else, they might mention an upfront cost, but really then you also have to say, is that ongoing cost? And especially if your grants or budgets might not be 100% rock solid, that's a pretty scary prospect, possibly to be 5 years in and suddenly your funding gets cut 50%, and it's either you can either have staff or some data support. Choose one. That could be an unpleasant prospect.
Yeah, this is Kathy in Massachusetts. I agree with that assessment, that it just seems like a lot of birth defect programs might be at the mercy of what their program, you know, like their IT department higher up do in that way. You know, you just go along because of the cost. Because I know, like, the people in our state, they said, oh, we transitioned a program that had a couple of spreadsheets into Apex Oracle. And that, of course, that was no problem. They were working off spreadsheets, you know, for their whole whatever program it was. So we're a little bit beyond, you know, to say the least, a couple of spreadsheets. And I think they came to appreciate that. But I know our database person who created our system, who maintains it, who is an access expert, had said what I heard someone say. He said, maintain access as the front end and do SQL Server as the back. That makes sense, you know, that because we're too complicated. But I'm not sure that kind of message, they were already into the Apex Oracle, you know, mode. So just that's a little bit of a concern that, you know, yeah, that's our concern, you know, just how much can this Apex Oracle and kind of support the interactive kind of structure that we need for birth defect surveillance?
I mean, as Kathy mentioned, we have all these questions. So I was wondering if anyone has experience like with transitioning from Access to Apex Oracle. And what actually like is something that we are like trying to figure out is what is the way to do this transition, to do it that you get a system that is as helpful as the Microsoft Access that can like do all the functions that you have been doing, but also it's like a system that is being reimagined to really do more things than your previous system. So to kind of like justify this transition, like if you see advantages, if you see things that you couldn't do before and now you're doing them, I would be really curious to hear about that.
The silence is somewhat ominous.
I feel so too. So nobody has transitioned to Apex Oracle? Because we would like also, like, I'm not sure if someone who is not right now on the call, because we would be interested also in looking how it, like how it looks before, like to see like how this system would look like for us, because it's difficult to imagine it without seeing another one.
Hi, this is Carrie from Washington. We are in the process of transitioning from a passive system into an HL7 kind of SFT system that will be in a SQL, I believe, or Oracle database. But can't tell you what that really looks like yet, because we're in testing right now. So hopefully in the next few months, we will have something that we could maybe share and show people, but still super, super, super new on our end.
So you said you're in a passive system. Can you elaborate?
Yeah, so what we were doing was wildly inefficient, but we were having facilities send us their data via CSV or Excel spreadsheet or HTML in some cases, whatever they had, directly to us. And then we had an IT person who was sending that to one of our, I guess, a systems person who was then assigning, variables to everything and putting them into a SQL database from that side, and then exporting them back out to us in CSV for analysis and data. And so it was kind of and still is messy and really time intensive and a lot of work, and not a real super efficient system. So hopefully we'll be improving on that. But the new system is not going to roll out all at once. So it will be facility by facility. So there's going to be quite a bit of transition time until we have everybody up on HL7 and reporting the same thing across the state.
And what triggered this transition? Did you want to gain the increased functionality of HL7, or?
I think it was just I can't say for sure. I'm brand new to the position, so I'm not sure what the impetus was for moving, but I think it was kind of trying to future-proof the way the data is coming and what we expect in the future for getting this data. And then we wanted to do a better job of surveillance. We just aren't feel like we're doing the best job we could do. So we were hoping to kind of just standardize, and that seemed to be a good standard. I don't know if there was more. I'm sure there was, but I don't know what the other discussions were around that decision.
Yeah, so that's definitely interesting. And, I've been part of a work group, some probably other people on the call have been part of it too. I'm working with a group through Altaram and PHII, where we've developed the standards for birth defects reporting through HL7. And I'm going to assume that you guys know about those and know how to access that to use. But what I'm wondering about is what kind of data streams do you anticipate working with? I heard you mention hospital, but are there other sources you'll be able to access for potentially identifying birth defect cases?
That's such a great question. I am not sure what the plan is and how many different types of data streams we're looking at having. So that's a great question, and I'm definitely going to bring that to the team. So I'm just not sure what's going to be there.
It. Yeah, there actually is some potential for accessing data on genetic testing as well as lab potentially, and also you can get some informative information that can help you to sort things out in terms of medication use for certain conditions. You know, if you're trying to really figure out, is this really an ASD, and things like that. So there's definitely, but nobody's really implemented a fully functional system that I know of that takes advantage of all the potential of HL7. I think that's still pretty experimental, and we'll really be interested to hear more about your experience when you get it set up.
Yeah, I'm Simon. Maybe I could.
Oh, hi, Simon.
Hi. Yeah, thanks, Carrie. So Carrie and I, we are on the same theme, and currently we are working with vendor to build a data system for the birth defect surveillance. So one of the challenges that Carrie mentioned is, for example, we have facilities, hospital that will send us their data, but it goes through SFT, which is a secure file transfer. And then the HL7, the challenge is the fact that we have some facilities using version 2, some of them version 3. So, and we are anticipating a standard to standardize the HL7 message across all of the hospitals. So I think the challenge is like, okay, which one should we be picking up? So how do we make sure that going to some of the facilities say, hey, okay, FHIR is the fast interoperability is kind of new and then very efficient. So, hey, we want you guys to use that. How do we harmonize these things to make sure that not only we collect the data that we need, timing, but also we have the full, right? So I think
yeah, that makes a lot of sense. So one thing I would definitely recommend, and you're probably already doing it, is working with the other data systems within your agency that might also be doing HL7 messaging, because whatever standard you want to adopt really should be the same as other public health applications are standardizing around, right?
Yeah, that's correct. Thanks. Yeah, anyone that has that kind of challenge where you have, not only we have these kind of version that keep changing, and also there's no like a setting stone like standard, oh, we want everybody to be using CDA, or we want you guys to use FHIR. How do we get that one across to all of the hospital?
Right. So somebody from New Jersey posted in the chat. Do you want to talk a little bit more about what you guys are doing?
Sure. We are using a web-based data collection system, and I think is the backend is the PostgreSQL system. So it's a web-based system. You have a login for each hospital, birthing hospital. So the birthing hospital or other providers could log in to register a child. We also develop kind of like a batch processing, but it's fairly new right now. So we are still testing that part. So batch processing means if you have a CSV file, you can batch the whole list of your child into the system. And after the hospital registered the child, our state employees, our nurse will review the registration and confirm, if it's very simple registration, usually they kind of like everything makes sense, then they will process the child. But if there's any question and if there's lab need to confirm, they will call, or I don't know how they exactly confirm the case, but they will review the case and confirm each case if there's anything. And our system, you also have our mechanism. You can P means PE, the hospital means if you have a question, you can send the case back to the hospital, and hospital can put in additional information. And if hospital have a question for the state, they can also send a message within the system so that there's a two-way communication. Our system, there's another feature is connected to case management. So for New Jersey, the case management also use this system. So the case after registration, they release to case management, and the case management could follow up with the kids and then provide services. This is our front end of data collection. Then the data goes to the database. We analyze the data using SAS. Data is download from backend, and then we do epidemiology or other reporting based on the data, and also use other information we can get from the vital statistics, and then combine all the information together to do our reporting and other surveillance prevention research work.
Hi, so I just had a question on New Jersey. So do you abstract, you don't, sounds like you get a report, you verify it a few ways, but you don't actually go out and collect data. You don't go out and abstract.
We used to have a auditing component, but maybe we are not doing that after the COVID for right now. So we are still exploring ways to do that. But previously, we also have an audit component. So our nurse do go to the, but it's more like a quality control. So we compare, if we do an audit for the hospital, we compare our registration from the hospital and our audit list and see if there's a discrepancy, and if the hospital didn't report all their cases, we require them to register those cases and also give them a feedback, like what's the percentage you report, like maybe if they report almost 90% of their case, and why they miss some of the cases or why they miss some of the conditions. So they might register a child, but they might miss a birth defect condition. So we did have a auditing process previously, but currently I think it's stopped for now, and we are exploring new ways of doing the quality control. So we do have like a nurse going to the hospital. We have that part, but it's still a lot of change happened right now. So we are still trying to figure out what's the best way to do it.
Thank you.
This is Sukja from Minnesota. I have a question for New Jersey. So facilities, do they enter a case manually, or they do sort of upload questions?
I think currently they enter them manually, but we do build a batch processing process, but it's new. I think it's still kind of like a beta version. So the hospital still need to try how to use that. But I think previously they do enter the case manually.
This is Barbara from Minnesota. We did look at the questions beforehand, and so I gathered some more input from staff about what they like and they don't like about the Maven system. Maven, we chose to build it as a person-based system in Minnesota. So if a kid has a birth defect and later they get the flu, like the person record that the birth defect case and the flu case is connected to is the same. And I think that logically is appealing, but it causes some problems. Like if we get bad data imported, like through electronic labs during COVID, we put COVID on Maven. And so a lot of the COVID test results that came in had incomplete data, bad data, wacky things were happening. And it showed us how some of the volatility of a person-based system. So that's definitely an option for Maven. Texas, I don't think built their Maven system that way. And Connecticut, I'm assuming you guys didn't either. But we hope that the nice thing is that when people move, in theory, you know, we might have an easier time trying to find these families, you know, 10 years down the run. I don't know if that's going to be the case, but we hope to use it in the future to see if we can reach our families, you know, well after the first year of life. So I don't know, there's good things about it, like there's ways to customize your report out. We also have local public health nurses who do follow up with our families. They can log into meds and they enter the follow-up into meds directly. So that's kind of neat about it. But if the system gets a backlog, like if our reports are running slowly one day, then everybody's reports are running slowly. So there's a lot of system resources that need to go into making this massive system work effectively. I think from our side, it's worked pretty well, but it is big investment, and I think we could be if we hadn't gotten funded, it would be a much different picture.
That's all very interesting, and the discussion is very engaging, especially hearing like how people are like have decided not to migrate versus others that have migrated already or they are in the process. I was wondering if someone who has migrated already, like transitioned from the access to another system, can talk more about like the processes of migration, like what worked, what didn't work, and who was involved in the migration to make sure that the new system could do all the actions that you wanted it to do to be able to support the data collection that you were doing before with the Microsoft Access database.
Also, I would like to ask if Ogo Bear of California would like to elaborate. They spoke in the chat. I was wondering if they have voice capability. I would like to hear from them.
Yes, hi, this is Olga with California. Can you hear me? And we've never used Access. We started out, we also always relied on the in-house staff. So that's a little bit different, actually a lot different. But we started out back in the 90s with a FoxPro-based system. And after a while, Microsoft took it over and then killed it off. So we kind of had to migrate. We went with .NET SQL combination. I think the first one went live in 2009. So as far as transition, there is really a lot to unpack, and definitely working with the in-house staff is different from working with contractors or an off-the-shelf system. because then you have the opportunity to do this incremental development and gather a lot of input from the staff. You also have people that you can come to and have them plan changes. And our staff also has other data processing tasks, so we're not like full-time developers. I mean, I'll be happy to answer any questions if it's at all interesting. I'm also very interested in experiences of the programs that work with HL7 standard, because we haven't explored that yet.
This is Vanita in South Carolina. I'll just mention we have the opportunity and the buy-in from LabCorp here to get like V2, like the baby HL7 messaging from them. But during COVID, right before COVID, when they agreed to send us this data, you know, we were preparing for that, and then COVID hit, and we didn't feel like as a health agency, we should be adding that to their kind of list of things to do. So we've held off on it until now. So we're gonna be re-engaging them and exploring that information again, because we are allowed to get the data and because it's of great interest to our program. So we have consulted with IT. We can receive the data. We can receive it through an existing mechanism that receives, infectious disease messaging, but we just haven't done it yet. So the plan is to pilot it hopefully this fall.
Vanita, what sort of database does South Carolina use?
Oh, we are like, yeah, we have an access-based database as well.
Okay. Do you store it in Access or do you store it in SQL Server?
SQL Server.
Okay, so you use Access as the front end?
Yes.
Okay.
SQL Server is the database. Yep.
Okay.
So since you mentioned LabCorp as a potential input source, I'm wondering, several years ago, I looked at a project that New York State implemented to obtain results of genetic testing for New York residents, irrespective of where they might have been, where the lab testing might have been done. I just wonder whether New York is still doing that, if they have any experience, and possibly whether they've found a way to update that approach to use HL7. And there might not be somebody from New York on the call who can answer the question, but if there is, give that, well, that'll go in the transcript for follow-up then, I guess.
Bryce, I can also find follow up and get back to you.
Yeah, I mean, it was a while ago. It was when Ying Wang was still working with the New York registry. But usually when people set those kinds of things up, they kind of take on a life of their own. So.
Hi, Russ, and everybody. It's Michelle Hurd from New York, the Birth Defects Registry. We are not doing that.
Okay.
Ying was a long time ago, and it is not something that took on a life of its own. We are actually just trying to reconnect with the labs and things like that. So, because it did get dropped, there was multiple people in between Ying and me. So. Yeah,
I imagine so. Yeah, I just want to, it'd be worthwhile to explore it though, because, particularly for capturing additional cases of chromosomal abnormalities, it had a pretty impressive improvement in the overall prevalence of some of the conditions.
Yeah, we had just recently initiated a new reconnection, I should say, with our labs and did some outreach to labs. They're reporting New York State, so we'll see where that leads us.
Yeah. Well, I'd certainly be interested to hear as you move that forward.
Hi, this is Kathy again. I guess we are currently exploring some lab expansion as well. So if anyone has information, I'd be interested in that, in finding out more about what your experience, what you're doing, and kind of templates, things like that. And LabCorp, we currently get a report from them, so maybe there's a better way to get what we're getting if they have another method, HL7.
So I guess this might be, and forgive me if we need to go back, we can, but one of the questions we want to know about is, are there ways that NBDPN can support transitions to new data systems or ease the process of transitions? And I really want to take it even a step back and say, even support you with your current data system.
I mean, it might be useful when some programs has successfully transitioned. I mean, if there's some material that can be transferred whole cloth to other programs, that could be a big savings in time. Though I know each program has their own idiosyncrasies, but trying to help facilitate that would be useful.
So maybe a place to store lessons learned, and then if possible, the actual kind of infrastructure of the system.
Yeah, lessons learned, the kind of overall layout structure that seems to work would I'm hypothesizing, since obviously I'm not on the other end of that bridge. And who knows? I mean, is it also something that can speak of delete the sensitive data, copy and transfer, where that send off a whole bunch of proprietary problems with lawyers? I don't know.
Okay. Right now, our group, the birth defect and also the infectious disease, and also other groups within the Department of Health is talking about the interoperability. And we are thinking about, doing some system improvement, but it's hard to know the big picture. So I know in this call, some people talking about Marvin system, and I don't know much about that. So if NBDPN can put together, some big picture information, like if we want to, implement HR7, is the Marvin the right way to go? If there's other recommendations, that will be very helpful.
Yeah, so what you're hitting on, last year when we had a committee working on developing webinars, this was actually an area that we talked about. And this listening session, I think, is partly designed to get some ideas on what people would like to learn more about. And you've definitely hit on one that I bet a lot of people would like to learn more about.
Yeah, I think another way that the NBDPN can help is by maybe finding the programs that have migrated to other systems, and they can do some presentations around how their systems. I know they could be confidential data that you cannot look at, but maybe if there are demo systems that we can look at to see how things are working with systems that we don't have any knowledge about.
Yeah, and I agree. And also, I think we should learn from other system. It's kind of like a lot of registration, like surveillance system, have their similarity. Like national level, we have some surveillance for HIV, for the cancer, for the infectious disease. And I know immunization is also a big thing. I think every system, they have some national level coordination, kind of like even for the COVID, they have like a Red Hat. I think they use that. I think maybe NBDPN can lead in the national level to move birth defect and learn from the other system, like how they did the interoperability. I think infectious disease is, I think they are more on the front line, but I think NBDPN can lead in the national level to learn from the other systems how to organize, coordinate in the larger scale.
That's a really great point. And I wonder, does anybody have familiarity with how cancer registries achieve that, or perhaps newborn screening programs? Maybe there's other lessons learned to, from those types of surveillance programs as well.
I don't know about cancer, but in New Jersey, we are trying to, have user groups trying to learn from the other within the Department of Health, other programs. I think the COVID, they use kind of like a database called Red Cap, and cancer have like a coordination system. HIV, I think CDC have some universal reporting system. Infectious disease, they also have some coordination going on. But I don't know the details.
I mean, it sounds like there's definitely interest in learning from states that have, migrated, as well as from other types of registries. So that's definitely something for us to follow up on. So are there any other states that would like to add to the conversation in terms of what you would like to see from NBDPN and how NBDPN could facilitate or support some of your initiatives? Okay. Well, I don't know, Justin or Brendan, if you want to add anything, or maybe just, there's other questions we could go back to, but I mean, I definitely see a role in future discussions and bringing in additional information for states to learn from other states.
Yeah, definitely like a lot of things for kind of mull over that were discussed here and things I've learned.
Absolutely.
I mean, there's like, I'd be like hearing that, all is not doom and gloom for the future of access. That makes me personally feel happy. Yeah, I think there's like, giving programs some backup when it possibly might get pushed around by IT about some of these issues. I mean, they may still have to go along depending on their circumstances, but at least having a better idea of their options and it would be useful. And also, I think they'll always age the question. I think this situation of, I think I have been approached by IT saying, "Oh, you probably should transition," and then again, I show them the diagram what's in my database and says, and they just, I just drop off the radar. They go on to bother someone else.
That's funny. Well, before we wrap up, I also, I've heard from several states, about giving input for future listening sessions. So do you all have ideas on things you would like discussed at these forums? So for example, any area really of birth defect surveillance, program management. Are there topics of interest that you would like to bring up now? Maybe we can discuss that and plan a future listening session around something like that. So are there states that have ready ideas for what you would like to hear?
So if any states transition from a passive surveillance to a active surveillance, I'd like to learn about the experience. So we are thinking about, looking in the future, how to better do our state surveillance, but we are still trying to figure out.
Great topic. Okay, that is noted. Thank you.
Yeah, I agree. That would be a nice conversation. What nice session to go over.
And I think like we would, I mean, at least I can say I'm interested also in adding new data sources, how states incorporate new data sources, whether it's, birth certificates, death certificates, other settings. I'm curious about how other states have done that. But yeah, I would like to leave it open for another minute or two, see if other respondents or attendees have ideas on what they'd like to talk about in this forum. It's for you, so please speak up. There is no wrong answer.
And I would run that actually beyond additional listening sessions. If there are topics that you think we should develop into webinars or be thinking about potentially building into sessions for when we have our next annual meeting, we get the best ideas for what we should do from you. So please let us know.
Hi, this is Sukja from Minnesota. I don't think it's a topic for listening section, but I like to actually discuss what's a potential impact of that NCHS decision on no longer providing race bridge variable. Because I heard from Minnesota Office of Viral Records, the National Center for Health Statistics is not going to use or provide population-based estimate of what race ethnicity based on the multi-race bridge variable. So it depends on the state. I think we rely on that NCHS multi-race bridge variable a lot. So we have to think about how.
So that's definitely interesting, and I'm usually not out of the loop, but I have not heard anything about that so far. Has anybody else also heard that?
I have heard that as well. We've talked a little bit about that in North Carolina because we use that variable too.
Yeah.
And I heard that the National Center for Health Statistics isn't going to calculate it anymore, but
it's still going to be on the standard certificate though.
I think so. And then I think I want to say the National Cancer Institute is going to start calculating it. And so we were told we might be able to get it from them in the future.
Not that single variable, that the race bridge variable, it is single variable.
Yeah,
incorporate like a single and then multiple, right? That that variable is no longer available. So you have to usually add other edited code or letters or a checkbox field.
Can you repeat what field we're discussing?
Okay, for birth defect, we usually interest in the maternal race ethnicity variables in birth certificate, right? To determine mother's race and ethnicity.
Thank you.
So it depends on state how they determine maternal race ethnicity. But in Minnesota, we largely use that the NCHS race bridged race variable is hard to pronounce. That variable is no longer available as of 2022 records, which include birth and death files. So I mean, so it'll be interesting for other states to how that kind of a decision is going to affect your state's prevalence or count estimate for based on the maternal race ethnicity. If you don't use, it's not a big deal, but Minnesota, we use that variable to determine mother's race ethnicity.
And so you don't have access to like or is it like to like the state's vital birth files, or?
We do have,
Yeah,
so it's
but
a
that's
totally
fine.
different, yes. Like, checkbox, you have a checkbox field, right? And they also specify fields, it's called literals. So they turn into those literals into that code, race code. And then they also receive, NCH edited code based on those checkboxes and the literals provided by Office of Vital Record. So it's called NCH defined edited code. No more single that variable. So we have to come up with how you write those checkbox fields or literal fields and edited code together to determine maternal race ethnicity, which is, different from the using just single race variable. So I'm just curious how other states actually determine maternal race ethnicity.
I mean, it might be like useful to have a conversation just specific to birth defects epidemiology and talk about some of the demographic data we collect to see how it's standardized across states. I mean, that might be its own session, right, Russ? Or Nina, I believe Nina is still on. I mean, I just think that might be a good kind of like, these are the things that we want to know about how you do this, and then come back together and compare notes or present, states present what they do.
Yeah, that could be a good standards and guidelines topic too.
Yeah, it's all definitely relevant to standards and guidelines. But I got to drop, but it's been a great call, and keep talking.
Well, I mean, I think to your point, you're right. Yeah, I think it's under SGSC, and certainly something that we'll note as well in terms of interest in this topic. Well, I guess like, I mean, are there other ideas? Anybody want to share any other like concerns or ideas for next listening session that we could take back?
I have a question. This is Wasserly from Massachusetts. I heard you guys talk a lot of the data system. So what is the idea or modern data system sounds like? What kind of feature you would be most important for the birth defect surveillance program? Except for funding, right? Right now, we talk about a lot of new concept, a modern data system, something like not only for data collection or receive report and also need to be able to share data with all other agency and how to utilize and analyze them and then visualization, things like that, and also need to be very fast and quick, and real-time record could come in right away and will inform policy and decision making.
You know, we're so like, we have sort of, I don't want to say stuck with, like, I don't mind our system, but I haven't had the funding to really think about what would I want and like the ideal system, but that's a really good like kind of point. Like forgive me if I'm wrong. I think you're asking like, what do we look for in a system in terms of data modernization? Like, what are we looking for? Right?
Yeah, because I feel kind of each time to migrate the whole system will cost a lot of the effort. A lot of people work on that, and then of course a lot of money too, and time and effort. So would it be good that we have a better idea to see what is the advanced technology right now and which the what is powerful? Just I mean, just look a little bit for not just a few next decade or something like that. At least you could. Yeah. No, it's just this time we have asset upgrade to from 7 to 10, and next time change to SQL, and next time, and then some years later and transfer to what? I don't know. Yeah, Oracle, I learned that Oracle will be the most powerful system right now, but it sounds like there are a lot of the other choices in the market. For example, New Jersey, you don't want PostgreSQL. Yeah, that's one of the option. I think there's some other option too. More and more coming out. I don't know. I'm not the people to make a decision, but it's just interesting to learn a little bit. And also CDC, the what they call the data, modern data initiating. I think they make a very good framework and idea. And yeah, they just get started, and they got some money from the CARES Act, the COVID-19 funding. So might be if NBDPN would reach out to them, maybe could share some support from them too, and that at the national level. So if NBDPN will be able, or CDC and the birth defect field can better share data, I think the multiple state project will be much more easier to share data than right now. They spend whole years and then work out each IRB and each state or something like that. I don't know, that's just the idea.
Yeah, I agree here. And from my understanding, I think that you can think about the first generation of software is Access, and a lot of states are currently using that. So, and also they have the pressure to move from Access to other more commercial database, like SQL Server, like Oracle is a larger database, and you can consider that as next generation of database. So I think we have some idea right now to move from the traditional database like the SQL Server and Oracle for now to a messaging system. But because it's still everything is new. The idea I think come from COVID is like quickly how you can quickly get the information. Like traditionally, you gather information with a delay, but COVID require you to know for now and give immediate report of that kind of situation. So I think the next generation from the CDC webinar and from the other collaboration within the department is move from the current commercial database to a HR7 messaging system. Is my understanding. Other people can say their understanding. So it's some people talking about Marvin. I don't know about the system, but it seems the next generation will be based on messaging. The data will be very quickly, get together.
Well, I feel like this was a productive discussion with a lot of great follow-up items and some ideas for next sessions. Unless others have ideas they would like to add, I would consider wrapping up. Brennan, do you want to add anything, or Justin?
I think I agree. It was a great session, lots of good points, and I've learned lots of things, and hope everyone as well also learned many things. Yeah, I'm happy to wrap up now. I think give people 8 minutes of their life back.
Well, thank you all so much for attending. We really appreciate it. All right. Thanks all. Thanks, Brennan. Thanks, Justin.
And thank you, Vanita.
Take care.
Thanks. Bye.
Bye.
Bye. Thank you.